Continuing with our technique classes, sixth episode in the series, Concepts and Issues. In every episode, we take a look at 10 points in the area of technique. We have covered 50 points till now. Today, we'll cover 10 more points, 51 to 60. These are some of the things we do in therapy. We had discussed before how dealing happens and what all works in therapy. And we said it is not one thing, either related to thought or affect or behavior or reliving or catharsis that solely works in therapy. Therapy includes everything, regardless of whether it is politically correct or not correct, in vogue or not in vogue, liked by supervisors or not liked by supervisors, appreciated in papers or not appreciated in papers. Regardless of all of that, what works continues to be used in therapy. And what works, experience tells us, is a basket full of tools. We realize very soon in the process of healing the fundamental principle that everything works on someone and nothing works on everyone. So we need a basket full of tools cutting across schools, approaches, paradigms, and whatever works. Knowingly or unknowingly, we use it or we are forced to use it. So let us look at some of the things we do, some of the tools we use, regardless of what people say about it. Let us take 10 of them and discuss in brief each of the 10. Detailed discussion will render our discussion into a book by itself. So in limited time, let's discuss in brief each of the 10 things that we do in therapy or tools that we use in therapy. Preparing for interpretation. It's very important to understand that you don't have to interpret every time you can. This is very important. Supervisors usually force people to interpret and not to miss a chance of interpretation, because thereby it is said you miss a chance of healing or contributing to healing, which is not in your interest as a therapist nor in patient's interest for quick recovery. However, situations are far more complicated and often it is not possible to give an interpretation without causing unbearable difficulty to the client. This can result in a situation where it is said, brilliant interpretation and the therapy ended. So to prevent that kind of situation from happening, to avoid loss of the patient or even a possibility of loss of the patient, and to calibrate your interventions, your interpretations to the extent that the patient can take it, often we have to prepare for an interpretation. And often we have to defer an interpretation. Deferring will take up slightly later, but let's take up preparing for an interpretation. Take an example. Somebody comes with an OC and you realize after taking the case history, it appears to be a situation where Freudian explanation of entanglement in the Oedipus can be the reason for the obsessive compulsive disorder. If, if this is your analysis and you ultimately have to go to the Oedipus and some material comes up which possibly can be linked to the Oedipus in the session, question is, what do you do? Unexperienced approach would be to jump at the first instance where you can interpret and go to the core of the problem. Experience, however, tells us, particularly in traditional cultures where talking about Oedipus is difficult, almost scandalous, an unprepared opening up of that discussion can be disastrous for the therapy and for the therapist. So we have to prepare for interpretation. And that can mean opening up discussion on sexuality, going into masturbatory fantasies, looking at central masturbatory fantasy, looking at consumption of pornography or fantasies, and then, if necessary, maybe bringing up in the third person or without any person something related to Oedipus tangential and preparing the ground whereby the person gets ready for a discussion on Oedipus. So we have to not only defer interpretation, not only let go of an opportunity to interpret, but actually prepare for interpretation. So this is one of the very important things we do in fragile situations, in unbearable situations, in culturally very taboo situations, that we have to prepare for interpretation. And this is a very important element for therapy work. Because if interpretation is so difficult, the question of challenge, collision, or head-on collision, confrontation, challenge, or head-on collision just does not arise in that situation if interpretation is so difficult. So regardless of whether you are doing intense therapy or classical therapy, in fragile, unbearable, culturally taboo situations, we have to prepare for interpretation. It's a very important element of therapy. Second is naming. This is to give a phrase, a word to something which is very amorphous, difficult to bear, perplexing, confusing, anxiety provoking, or shame provoking, or provoking of any negative effect. And one is able to only faintly gauge what it is, but not able to fully make out what it is, not able to articulate it fully. And this is very important, giving name to the nameless. That nameless dread, it was put into end. It's put to an end with naming. Once you give a name and it's convincing, suddenly there is a sigh of relief. The dread of an infinite unknown reduces to a very manageable anxiety, or if not manageable, at least engageable anxiety of the difficult known. And this is very important because everyone reports a lot of relief just by naming something. For example, somebody talks about a very difficult to describe dread after finishing a conversation with somebody and the person goes away. And if we use the word abandonment, and if it strikes a chord in the person, if this is the right name for the what he is feeling, suddenly he feels relieved. Just as making something conscious strips it of much of its power, similarly, naming something unnamed strips it of its difficult power. So naming is something that we do, and we do it in two ways, either in the colloquial language or in the technical language, based upon the client that we are dealing with. But naming is very important, almost as though you are converting something beta into alpha in Beyond's language. In Lacan's language, you are giving a signifier to something which is otherwise a difficult thing in the real. And naming is an art because often we only have to name a phenomena technically, conceptually, academically already known. So there is a technical name for it, and we know a colloquial name for the technical name. But often we have to be in tune with the patient and be very good in language, very good in intuition and creativity to do the right naming, to do an impressive naming, to do an effective naming, to do an acceptable naming at times. The same thing could be expressed in two different ways. One name is correct but difficult to accept. The second name is correct and easy to accept. So naming is a very intuitive art, important in therapy. Normalizing. Often some people feel, or patients, clients feel that they are the only one condemned to suffer this sickness. And what has happened to them is something terrible. And this can go for a diagnosed DSM kind of difficulty or something which is a difficulty but not described in DSM. The moment they come to realize that this is a difficulty of hundreds and thousands, and many have got cured out of it or many are managing it very well, they don't feel the intense shame, the intense lonely condemnation of oneself. And they get rehabilitated because it has got normalized in the form of an accepted sickness. What they thought was a shameful abnormality, something for which they would beat themselves up as to why they have it, suddenly becomes an acceptable, ordinarily described sickness, and that normalizes to a great extent something that they were before feeling as infinitely troubling, infinitely shaming, and oneself to be a condemned one, or oneself to be a defect, a person with a defect, because of which this has occurred to him. Once you say this happens to many, and if the person is led to or by himself reads the public health aspect of it, the epidemiological aspect of it, and starts reading, seeing videos, being knowledgeable, he suddenly feels that from a level of -10, it has got up to the level of -2, which is far more bearable. It is still a sickness, but a very ordinary sickness. It normalizes him and to a great deal normalizes the sickness. And this is at times we have to do when it becomes unbearable for the person to not accept his sickness. I mean, accepting the sickness becomes unbearable. We may have to help the person accept the problem, see that it is a very pervasive problem, and help the person to get into a state of being sick but normal. We have to normalize the sickness. We have to normalize the person first, and as far as possible, normalize the sickness. Joining to a community. This continues from normalizing. It is further normalizing by joining to a community. Once you bring in epidemiological and public health aspect of it, and you bring in success cases, and you bring in celebrity Also personalities who were once into it, got cured, or are with it and yet are celebrities. Or when you go to the past celebrities who had this problem but still were geniuses, the person feels belonged to a community. And often after this feeling in therapy, the person can go and join groups online or otherwise, like Alcoholic Anonymous or OCD groups or any other group on social media, social support groups. And this joining into a community provides social support, knowledge, access to resources, opinions on professionals, what are the dangers of particular medicines, and a host of holistic healing tools which are experimented with usually in a social support group. It also becomes a semi-therapeutic space to release and vent out one's feelings and get support from the community. So the graduation of normalcy is into feeling joining a community and feeling normal in a community and get supported by the community. So we start as a therapist, we may have to normalize, we may have to encourage a person to first intellectually feel he is into a community. He is not the lone condemned one. And then support him to join a community if he feels like. Passing exams. Now this is something very subtle, and many times this is an exam held by the patient and the therapist has to pass this exam. In patients who have been deeply hurt in the past, they can't trust anybody because they have been hurt repeatedly. So before they get emotionally close to you, before they open up completely, they will put you through examinations. And you never know how it is coming. It might be that they ask you suddenly for a session. They ask you to do therapy without getting paid for 3 months. They ask you whether or not they should carry their medicines when they are going out of the city. They may ask you if you would like to talk to their parents. All of this, some of them can even try to seduce you. All of these are examinations in this group that I am referring to. And unless you pass those examinations, they cannot come close and cannot open themselves up, and therapy work cannot happen, deeply speaking. So this is something very important we have to realize when the exams come. Often we don't realize, we can't, but we have to keep this in mind and do our best. And this is something where luck plays a very big role. At times the person can ask you, when he's talking about his adversary, and he says this is it, and he suddenly feels you are not inside on his side, and he asks you, are you with me or are you with him, the adversary? And those are the times you may have to cross the boundary and say I am with you, because otherwise it can be end of the therapy. And after some sessions you can come back to it and say that this is not something that I should be doing. I cannot become a player in your life. I have to be a referee, and I cannot take these positions. So the next time it does not happen, but in certain situations, you have to get into exceptions and pass the exams. Differing, not doing an interpretation. This is very important. You don't have to interpret every time there is a chance to interpret. Because if you start doing this, You will have a chance to interpret every few minutes. Anything somebody says can be interpreted in terms of the unconscious and psychoanalytic theory, and something can be said about it. Just because it can be said, you don't have to say it. So don't go manic and keep doing interpretations every few minutes. You don't have to do 25 interpretations in 1 hour. An optimum number of interpretations done at the right time and a right gap between different interpretations works much better than doing too many interpretations, and that just becomes a habit to hear and nothing moves inside. When you do something too much, the significance of it drops. And often the person may not be ready for an interpretation. Like a narcissistic person, if you interpret the narcissism too soon, it may be the end of therapy. A person who cannot, a fragile person who cannot accept that he has a problem, if you insist on the problem too soon and too much, it may be the end of therapy. A person who has regressed to the state of primary narcissism, if you insist on reality acceptance and giving up the addiction to the bliss of primary narcissism, it may be just the end of therapy. If you ask a fragile person to allow feelings to come up too soon, it may be the end of therapy. If you do Oedipal interpretation too soon, particularly in a conservative society, it may be too soon and can have difficult effects on the therapist and the therapy. So we don't have to interpret every time there is a chance to interpret, and often we have to defer the interpretation till the person is ready. So deferring is as much important, right timing is as much important, doing an optimum number of interpretations in a session is as much important as the interpretation itself. Natural acceptance. It's almost like saying a Jungian archetypal acceptance. The acceptance of men being different from women, the acceptance of the child being different from an adult, the acceptance of an old person being different from a middle-aged or young person, the acceptance of the hierarchy in society, the acceptance of aging, the acceptance of letting go of what is unachievable, the reality acceptance. That reality acceptance, the natural acceptance, is something we have to slowly cultivate. And that's a very important part of therapy. The acceptance of the natural and the acceptance of the real. And this is where too much of political correctness is preventing natural acceptance and leading to rootlessness and being unanchored in the deeper parts of oneself, where one is living a superficial, politically correct life without any roots, without any feelings of being anchored, rooted, wholesome, cheerful, and happy in a rounded, grounded sense. And this needs some infusion of Jung's approach and some infusion of naturalism as a philosophy. This, of course, is not something which is mandatory for every school. but I believe it should be done in therapy, overcoming the political correctness which is strangling psychoanalysis and most forms of psychotherapy and most forms of public discourse today. Mysticism. Elements will come up in psychotherapy where the mystic part is brought up in discussion, or there can be a mystical explanation to something. You can always give a rational explanation or say, I don't know. But to have a rounded therapy, the engagement with the mystical, the irrational, the suprahuman, the transpersonal, that makes it more rounded. It makes the person more rounded, it makes the therapy more rounded. It makes quality of life much better. So if quality of life is the goal beyond cessation of symptoms, then mysticism has to be engaged with. Of course, here one needs a lot of reading and knowledge of mysticism, spirituality, and often one may have to say, I don't know. But if one has it, one can do a much richer therapy than just confining oneself to the rational and keeping away the magical and the mystical. Good goal is a very important element. Psychoanalytically speaking, in a Puritan sense, we don't go to the goal. We just ask the person to make his choice. And we don't really play a part in helping the person create a good goal. And this goes to the extent that many therapists today forget that it is necessary to have a good goal. A good goal gives not only a direction to the person, not only enhances the quality of life, not only brings focus to the efforts and increases the return on investment in terms of efforts, not only brings the person more productive achievements, more gains in real life and emotional life, but a good goal also evokes the positive aspects of the superego. The superego strength, the superego happiness, the superego resourcefulness, which we have not tapped in psychoanalysis. We talk of superego pathology, but not superego health and superego resourcefulness. And this is something the good goal brings. It evokes the superego strength, creates superego happiness, superego resourcefulness is evoked. And the person is able to do a full articulation of desire, because you cannot reach the good goal unless you go into articulation of desire. And that is a very important aspect of therapy. Full and exhaustive articulation of desire, and then to create good goal in the light of reality acceptance. And a good goal is not a token goal to just tick a box and completes a formality on the page. It is something that has to inspire, motivate, give positivity, energy, and happiness, and bring about creativity and playfulness. Otherwise, the good goal is not really the good goal that we wish to institute or help institute in the client's life, in the client's mind rather. Freedom. This has to be a constant engagement, how to be free from the symptom and the surroundings and exercise one's choices and explore who one is apart from one's pathology and apart from one's conditioning. And that inquiry into authenticity is very essential. So the freedom from pathology, freedom from conditioning, freedom from present situation, as Hegel would say, to see the present with the eyes of history, to see oneself with eyes of freedom. That is a very important element. And many clients for the first time ask themselves what do they want if they are free from pathology and their immediate conditioning and constraints. And the real articulation of desire gets facilitated. So the freedom from conditioning, from pathology, from situations, and living in a state, at least in the therapy session, and if possible, as possible outside of it, in a state of freedom, where one can do free reflection, free choices, free articulation of desire, and free expression of oneself, free acceptance of oneself, and being free to be oneself. So as much of that can be facilitated in different situations that are being discussed in therapy, more holistic and priceless therapy becomes. We're done with 10 points today, very concisely. Each of them can be dealt with at length some other time when we have it. Next session, we will take up 10 more points related to technique. If you feel there are some points I should take up, write to me. You can write at hvindia@gmail.com. Thank you.